TopMedTalk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on TopMedTalk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
This piece is presented by Paul Wischmeyer, Professor of the Department of Anesthesiology at Duke University.
And our medical education is not something we receive. We know that more than 75% of medical schools in the U.S. and in the U.K. both teach no meaningful clinical nutrition to us as young physicians. And we know that only 15% of graduating registrars feel at all competent to discuss any nutrition with their patients. So this is not something we're taught to do and not something we're taught to think about. But I hope to compel you to believe that it perhaps is one of the most pressing silent epidemics facing our patients today. Just in brief, I would like to call them alignments of interest rather than conflicts of interest, because I'd like to believe that everybody that I work with up here and I have the same goal that all of us have, which is the best possible patient outcomes. And so I would like to see them as alignments. And the point that I hope, if you remember one thing that I say today, and I'm going to cover nutrition in two lectures, the pre-op nutrition in this one and the sort of intra-op, post-op nutrition in the next one. But if you remember one thing, it's this, that no malnourished patient should ever have elective surgery without being screened and, if diagnosed with malnutrition, treated. And that happens, I would advocate to you, all the time around the world. And to exemplify that, I want to tell you about a patient I took care of not so long ago. Well, I was at the University of Colorado. His name was Joshua. And he was a 23-year-old young man who had Crohn's disease. He was otherwise without illness, but he'd lost a significant amount of weight because of his Crohn's disease prior to his surgery. And he had a very low BMI. Despite that, he went to surgery, and this was at a small hospital. I'm from Colorado originally before I came to Duke, and we had a lot of small mountain hospitals. And he went to surgery despite all of this malnutrition, and really the question would be, is he ready for surgery? Should he have gone to surgery in the first place, given that he was clearly malnourished when he came? But that happens commonly, and so what happened to Joshua? Well, he did well for the first 2 days, but then on the third day he developed a cough. He became short of breath, had a fever, was diagnosed with pneumonia, placed on antibiotics. But unfortunately, things worsened for Joshua. The next day, he developed septic shock, DIC, and developed a large abdominal hematoma that the physicians, the surgeons, and the team at the small hospital didn't feel they could care for. So they flew him to us at the university to care for him. And we took Joshua to the OR, evacuated the clot, treated the bleeding, brought him to the ICU that I happened to be attending in that week. Sadly for this young man, just all the shock and bleeding led to his abdomen being left open and him evolving ARDS. And he went through all the things our critically ill patients go through after surgery, unfortunately. And perhaps most troubling, he continued to receive poor nutrition in his care, and the story's always the same. He didn't get assessed preoperatively. He didn't get nutrition intervention preoperatively, and then he was left MPO for days waiting for the magical bowel sounds that we know, of course, have no relevance to feeding. But unfortunately, of course, when you don't feed the stomach, it will become akinetic within 24 hours. I'm a recovering burn physician, burn intensivist, and we know if you feed a burn patient the first hour of their injury, you'll feed them for a month. And if you wait a day to feed them, you won't feed them at all. It's the same in surgery. It's not our surgeon colleagues' fault they have an ileus. It's our fault for not feeding them soon enough. And then when he did tolerate feeds, of course, it taking an act of God to start tube feeds, and unfortunately my hospital, the nurse going to lunch to stop them, he got half of what he needed. And he didn't get what he needed and developed a large caloric debt and large protein debt. Despite all this, he's discharged 48 days later, not to home, of course, but to a long-term care unit. And I asked Joshua the day he was going home about what he thought about his care, because I can tell you as physicians, we thought this. We saved him. We made him better. And that's the question. Was he a success at this point? And what did he think about that? This is what Joshua told me. He said, I'm glad I'm leaving the hospital, but unfortunately, I can't even feed myself or swallow because I'm too weak. My throat's too weak. I have to learn how to swallow again. I can't stand, walk, or dress myself because I'm too weak to get out of bed. In fact, his number one complaint when he left the hospital wasn't any of these things. It was this. He couldn't even change the television channel with a remote because his hands were too weak. Too weak. So Joshua goes to rehabilitation and, works to do his exercises to get stronger. And I get a phone call from his dad a month later. And I'm anxious to hear how he's doing. And his dad tells me that the day before Joshua was doing his exercises and suddenly had chest pain and a sense of impending doom while walking in the hallway. Moments later, this 23-year-old was found on the ground in cardiac arrest. He got CPR for 40 minutes on the floor of the rehabilitation center. And moments later, he was declared dead. What did he die of? He died of this. He got a clot from immobility and died of it. What happened to this young man? He should have lived, right? I mean, we treated his IBD, we treated his sepsis, we treated his surgical issues. What did he die of? He died of this. Right under my nose, and I'll never forget him. And how common is this? Because nutrition was neglected, and it was an emergency for this patient, and is this more common than we know? And moreover, if this is true, we need to be better. We need to be better than this. And how can we do that? Well, how common is this? Well, I can tell you that a third to a half of every patient admitted to the hospital is malnourished when they come to us. It doesn't matter what unit you work on, what country you work in, or what you do. This is just true. It's been published innumerable times. The U.S. looked at millions of patients in our large Medicare and HCUP databases, and we found that 1 in 3 patients is malnourished in the U.S. as well. But only 3% of those were ever diagnosed. So only 1 in 10 patients is ever diagnosed. More troubling, even fewer are actually treated. We found that only 10% of those diagnosed with malnutrition actually received meaningful nutrition intervention of any sort. So only 1 in 100 patients, malnourished like Joshua, is being treated for their malnutrition. Again, I'd like to compel you to believe this is perhaps the most pressing silent epidemic. I heard yesterday all the amazing things the NHS has addressed. Could this not be next? When are we going to address this and make this something that if we don't screen for, if we don't treat, we're not paid for? In GI surgery, it's even worse. 2 out of every 3 patients coming to GI surgery are malnourished. We know that from a large body of data. Is this related to outcome? Well, I can tell you in 1936 it was. If you had a peptic ulcer surgery in 1936 and you hadn't lost weight, you were going to live. If you had lost weight, you had about a 10-fold chance of dying. Just that factor alone. Are things different now? Say GI oncology? Not so much. If you haven't lost weight, you're likely to live and do well. If you have lost weight before your surgery and this isn't intervened on, the risk of dying continues to be high. And again, you're likely to not have a complication coming in not losing weight, and you're likely to, or almost assured to have a complication if you have lost weight. So this is a big issue, and this clearly impacts on costs and readmission rates. Malnourished patients have much higher burdens of cost and care. In fact, this is, I think, one compelling piece of data. Show that being malnourished at the time of surgery led to a 16-fold increase in central line infection rates. Things in the U.S. we're not even supposed to have happen anymore. At least we don't report them. But clearly they happen. I know in the U.K. they laugh. Mervyn Singer laughs at me all the time when I tell him my ICU has no central line infections. So low albumin predicts mortality in surgery quite accurately as well. Not the perfect nutrition marker, but a good preoperative marker, I will tell you, of risk of malnutrition. This is from the NSQIP database, about 2 million patients. It's the number 4 cause of 30-day mortality from all causes in all surgeries that are recorded by NSQIP. But if you look at this list, all the other factors on the list are not modifiable in the month before surgery. We can't bring these patients to Saul Aronson's PASS clinic and do things for these other pieces, but we can for nutrition. It's the only modifiable risk factor we have in that group. And the reason it gets so little attention is patients don't die of malnutrition in the hospital. They die of malnutrition shortly thereafter, like Joshua did. And so we don't see it in our patients. We don't see it in our day-to-day practice. This is happening in rehab centers, in nursing homes, and in patients' homes more often than it's happening with us. So I'd advocate this is an emergency in surgery, and we need to be better. And so I think, as Tim mentioned, one of the goals of ACER's nutrition guideline process was to try to do this. And I got to work with a wonderful group of people to try to address best practices in our surgical patients' nutrition care, both before and after surgery. And of course, ERAS is always, as Tim said, implied that nutrition is essential to a successful ERAS program. And so we tried to address what the best evidence was and what the best practice was to do that. This was published actually in print just a month ago and came out online about January of this year. And the key take-home points are a few of these things. Infographic to convey them. Again, 2 out of every 3 patients having GI surgery are malnourished. And this leads to a significant increase of risk of death and infection and complications. But only 1 in 5 hospitals, major academic hospitals, have a screening program to even look for these patients in major GI surgical conditions. Surgeons believe this is going to make a difference. We did a survey of all the major surgical academic centers in the U.S. that do GI and oncologic surgery, and 80% of the surgeons said, we know this is important. We know this will change outcomes if we address it. And in fact, we have data that every dollar you spend on those little nutrition drinks that you can buy at the store and drink saves $52 in hospital costs. That's from 1.5 million U.S. patients, that data. But only 1 in 5 malnourished patients ever get them. So no one's being treated for this. And so we tried to come up with, and this was Mike Grocot's suggestion, come up with 6 simple concepts. And clearly screening being essential. None of the others will follow if we don't have that. Protein more important than calories. It's true in our daily life as well, probably. Stop feeding late, start feeding early. Oral nutrition supplements for all, before and after surgery. Oral first, parenteral as the last resort. And nutrition is a team game. Your dietitian, your entire preoperative setting needs to be incorporated to make this work. So our consensus statements, and I won't cover them all, but I'll cover some highlights in the preoperative setting here, were as follows. So clearly we recommend that we have to screen for malnutrition to find it. How Joshua wasn't identified as someone who might be at risk for surgery baffles me still, but it happens all the time because we don't have a simple way to screen. You'd think it would be easy, but we know it's not. In acute care surgery, we know that almost half the patients with malnutrition are never recognized, and many of them are never screened after acute abdomen. We just aren't picking it out. And so, again, this is the survey I mentioned to you, looking at both GI and oncologic surgery fellowship programs in the U.S., supposedly the best of the best in our academic practice. And only 38% of these had any formal screening processes available to them, and only 20% were giving any nutrition to their malnourished patients. So even in our best centers, this isn't happening. But all the surgeons believed this was important, that they knew that we've addressed this, their patients would do better. It's just we don't do it. But they all felt like they didn't have the knowledge, and I think all of us would agree we weren't taught this knowledge, for instance, around immunonutrition, which has a lot of data to it, but none of us are taught it. They didn't have the knowledge to understand how best to give it, and they wanted protocols to help them. And so we said, perhaps we can do that. And so as part of this process, we developed a screening score that we've built at Duke into our electronic medical record called the PONS score. And it's simple. Do you have a low BMI? Have you lost weight without trying in the months before surgery? Are you eating half of what you usually eat of your usual meals? If you have any one of those positive, you're at risk. These are drawn from other validated, published, evidence-based scores. And then is your albumin low? We even dropped it to 3, but this group data would say even 3.5 matters, and I can tell you low vitamin D puts you at risk of immune dysfunction and higher risk of infection. And so if you screen positive for any of these, we want to see you. We want to see you in our POET Nutrition Clinic. In another setting, you should be intervened on. You should get malnutrition interventions. And so at Duke, we've tried to create a whole continuity of care for this that we hope others will want to replicate. And this ranges from preoperative to inpatient to postoperative. And part of it starts with the PONS score, this scoring system in our electronic medical record. And then we have an inpatient team that I have the joy of directing all these different pieces and have different team members that cover all the different pieces working with our surgeons. And then postoperatively, we need to continue to follow them. And our first recommendation nutritionally was protein is essential, more important than calories. In the ICU, we're beginning to learn this as well. 1.2 grams per kilo per day, which will be the new U.S. RDA, I will tell you, in elderly patients, is the minimum. Why is that? And we know that surgical catabolism occurs when you have surgery. You break down muscle to free amino acids to generate energy. And again, early protein is needed to keep you from wasting significant amounts of muscle, and we'll talk more about in the next lecture. These are the guideline recommendations of all nutrition and most societal guidelines, 1.2 to 2 grams per kilo for the surgical or critical care patient. Interestingly, the trials, large-scale clinical trials, at least in critical care, seem to back this up. If the trials give additional nutrition in one group and less nutrition in another, but don't get above a gram per kilo, no matter how many calories they give, no benefit of nor nutrition. All the trials that get above a gram per kilo, published in large journals, show some benefit on an outcome, whether it be mortality, whether it be time on the ventilator, whether it be another endpoint that's clinically meaningful. And there's good reason for that. We all know just as we age, we become more anabolic resistant, which means for the amount of protein we take in, we make less muscle. Of course, you don't have to lose muscle as you age, and it takes more than eating right to look like that, but you can maintain muscle. We see it all the time in our elderly patients who exercise and take in more protein. But you need to do it in a certain way, and the cancer docs know this. We just haven't figured it out in the rest of the world, and some of this is bolus protein, given at a sufficient amount, combined with exercise. You can maintain lean body mass in almost any age doing this. But surgery and critical illness lead to dramatic anabolic resistance, hence why more protein, far more protein, is needed to maintain and rebuild lean body mass and perhaps other interventions like testosterone or growth hormone or beta blockers to even perhaps improve our patients' chances of walking out of the hospital, not rolling out of the hospital to rehab. And this is a big issue. 60 to 80% of our ICU patients, you heard Dylan Dennehy, who's one of the masters in the world, talk about it today, are physically impaired for months to years after ICU and even after surgery. This is true. I will show you more of that later on. And this is the question I want you to ponder as you think about what you do in surgery and ICU every day is, are we creating survivors with our wonderful medical technology and surgical abilities? Or are we creating victims? Patients that, like Joshua, never walked again and actually never went home again, never held their kids again, never walked down the street with the people they loved. So first, perhaps, could we have prevented Joshua's infection in the first place had we done some simple things before he had surgery? Some of our recommendations suggest that in a malnourished patient like him, we should use preoperative nutrition intervention with high-protein supplements and perhaps immunonutrition. What is that? Well, first, what's the data for nutrition delivery in malnourished patients improving outcome? This is just one study in gastric cancer that looked at high-risk patients like Joshua and showed that the high malnutrition risk patient had a much higher surgical site infection rate. But then they randomized them to 10 days or more of pre-op nutrition versus not. And they saw a significant reduction in surgical site infection. And that held up in further analysis. In fact, a 2.5-fold reduction in risk of SSI was seen if even just 10 days of nutrition was given. And so, can we simplify our processes in doing this? This is our process to deliver nutrition in our patients at Duke. So low-risk patients should be receiving immunonutrition, and I'll show you why in a moment. The high-risk patients who screen positive on PONS, we see a dietitian who then prescribes a structured nutrition plan for them using oral nutrition supplements largely. That ultimately then leads to a reassessment, and if they're stabilizing their weight, stabilizing their albumin, perhaps they're ready for surgery. If they're not ready for surgery. And we need to address, is this compliance? Is this another cause of their issues nutritionally? But again, we need to be putting a checkpoint here. Just because you can have surgery doesn't mean you should. You have to be ready. And this is an easy one to optimize with a good system in place. And so, again, if this is not going to work via oral nutrition, enteral nutrition is essential. And in fact, parenteral nutrition is even becoming more essential. Because we're learning now that parenteral nutrition is one of the strongest predictors of a good outcome in a patient who can't take oral intake. Putting a patient on parenteral nutrition for 1 to 2 weeks can markedly improve their outcome. It's a grade A recommendation of the European Nutrition Society. It's one of the very few we have in nutrition, actually. Grade A evidence-based recommendation for 7 to 14 days. And in fact, despite what you're taught in medical school, we have 4 large randomized trials that shows there's no relationship of TPN to infection any further. It is just as safe to put TPN through a central line as saline. And there are 4 large trials, one of which done here, the Calories trial, that document that. So again, this is a much safer intervention. But this immunonutrition story that so many of our surgeons and so many of our anesthesiologists feel they don't have knowledge of. What is the data and science for that? So why do patients get infections after surgery so frequently? Well, some of this is evolution. We know that when you have surgery or trauma, whether it's the tiger biting your leg off or the surgeon hitting you, you mount an initial immune response, inflammatory response. But you have to turn that off because you don't want your body to commit suicide in the process. And so then you mount about day 2 or 3 an anti-inflammatory response that leads to depression of cell-mediated immunity about day 3. Day 2, day 3, about when Joshua got his infection. And this is driven by exhausted neutrophils called myeloid-derived suppressor cells that deplete arginine in our spleen and lymph nodes and impair T-cell division and T-cell function. And they do this quite effectively. We're evolved to have this. Whether you're malnourished or well-nourished, all of us do this. Giving arginine back can defeat this, at least in the laboratory it can, and block all of these pathways. So we have a great understanding. This was discovered by the cancer docs and furthered by surgical physicians. So arginine malnutrition in surgery is evolved. It's a natural part of what is induced by surgery and trauma. Again, there was no trauma surgeon coming to get you thousands of years ago when the tiger bit your leg off. You had to have your own systems. And if you didn't get off the ground at day 3, you didn't get off the ground at all. Your body wasn't going to kill yourself. This is part of our evolution since cavemen. But now we want patients to live more than 3 days, and we want them not to get infected at day 3 and have the outcomes perhaps Joshua and others may have. And so is there clinical data for giving arginine back? And I will tell you that there is. Significant data. It reduces infectious complications by 40%, 3,000 patients studied, reduces length of stay by almost 2 days, and it doesn't matter where you give it. It's a huge effect, whether it's pre-op only, periop, or post-op only. All of these periods show the same benefit. GI patients benefit, cardiac and ENT also, there's good data to show benefit in these trials. There's a larger meta-analysis now in over 7,000 patients in Annals of Surgery recently showing similar benefit. There's multiple meta-analyses like this. And none of them observed a signal of risk. And again, this is not malnutrition. If you had surgery tomorrow or someone you loved, they should take this. My mom had cardiac surgery a few years ago. She's well-nourished, but I was sure she took this before she had her operation. And there's trials specifically looking at well-nourished patients. What about ERAS? Does ERAS negate the benefit? This was a trial done by the Spanish ERAS group, specifically looking at protein supplements versus immunonutrition. The immunonutrition group had lower infection rates in an ERAS protocol, with this being the only change. So it works in ERAS as well. Unfortunately, less than 1% of U.S. patients get this when we do surveys. So we need to be better. So as I close, why do I care so much about this? And why do I hope you do too? Well, how many of you have had surgery? Raise your hand. It's quite a number. How many of you knew that you're going to average 9.2 surgeries in your life, no matter who you are? Atul Gawande published this not so long ago. All U.S. people, maybe not in the NHS, but in the U.S., everybody's going to have 9.2 surgeries before they die. So someday this is going to be you if it hasn't already been, or it's going to be someone you love. And I will tell you perhaps, and this is what inspired me to study nutrition, it was me. This is me at age 15. This is where my passion for nutrition comes from. Like Joshua, I had IBD. And this is why he's so compelling to me. I was on TPN for a year. In the first month I had it, I got 40 units of blood, ultimately having 22 surgeries, leaving me with 160 centimeters of small bowel. I spent a year of my life on TPN and multiple times since. Despite that, and because of my nutrition passion, was in the best shape of my life a few years ago. So my son and I visiting my grandparents in Canada. I'm a Canadian citizen, dual citizen too. About a month later, I ate some quinoa. Don't ever eat quinoa. You'll be sorry. Got a bowel obstruction in Baltimore and flew all the way back to Denver so I could control my care. Showed up in the ED looking like this, rising lactate, bowel edema. We're terrible patients as physicians, right? And then a junior surgery attending who I trained as a resident in the ICU shows up to open my abdomen. And I said, oh, no, not that. So found a more senior surgeon who went with her, took me to surgery, and 8 hours later, ended up in my own surgical ICU where I practice with an open abdomen because they couldn't close me, much like Joshua, due to bowel edema. Was in the hospital 23 days on TPN. Pulled my NG tube out and said, I'm going to eat tomorrow. And the old-time surgeon said, you went for 3 weeks. Surgeons are always right, I've learned. Didn't eat for 3 weeks. Went from this, best shape of my life, to this, 17 days later, dropped 20 kilos. No one is immune to this. Imagine what your 7-year-old patients experience when they go through this. 17 days, 20 kilos. Couldn't walk down the block without being short of breath at the end of the stay. 4 or 5 months later, I couldn't pick up my own youngest son at Christmas because I was too weak to pick him up. Too weak. So I practice pre-optimization every day. Part of every day in my life. What does it look like? Tim Buckman, a name some of you will know, asked me to put this list together for a friend of his having surgery because he said, Paul, you always get better so quickly. How do you do it? And I said, well, it's not easy. I take a lot of things every day, every night, every morning. It keeps going. This isn't easy. So who's going to do this? And I exercise 5 days a week. There's even a gym the hotel will let you go to for free, I found out here. It's brilliant. But how many of us are going to know how to do this for our patients? Who's going to teach them? Who's going to convey this? The reality is you are. Even the most basic protein supplements can change your patient's outcomes. And surgical prehabilitation needs to begin the moment surgery is considered, not weeks after they're in the ICU. And it needs to continue after discharge because I can tell you for me, this is a personal passion because I'll be in the OR again. I tell Julie this all the time that she's going to look out. Because the next nightmare, 2 a.m. call she or you may get might be me. Or it might be you or someone you love. And so this is part of my everyday, and my dream is someday we can make this part of our patients every day before they have an operation as well. Because as Mike says, well, surgery creates a teachable moment where patients are willing to take in things they wouldn't do before, whether it be nutrition or exercise. And if you don't believe me, listen to my favorite mentor, Yoda, as he tells us what we need to do to help our patients.
You must unlearn what you have learned.
All right, I'll give it a try.
No, try not. Do or do not. There is no try.
That, I look forward to your questions in the discussion.
TopMedTalk.
Nick Majerison here. Thanks for downloading TopMedTalk. TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.